Good afternoon, dear colleagues. It's with great pleasure that I'm going to talk about the epileptic heart, a very fascinating topic that is unknown to many epileptologists and to most of the general neurologists. Here are my potential conflicts of interest. None of the mentioned companies has had any influence on the content of my talk. So this is just a recommendation. You don't have to take notes of my presentation. Everything is basically written in this very recent review that we've published together this year in epileptic disorders. Now, if as a general neurologist, you think about the interaction between heart and brain, you commonly think about different cardiomyopathies or cardiac arrhythmias that can lead to an ischemic stroke and then secondarily leads to epilepsy, or heart failure can lead to syncope that could be falsely diagnosed as epilepsy. But today we're going to think about how epilepsy actually modulates cardiac activity and how it could affect cardiac function. And to raise awareness, I make the first statement. People with epilepsy die 40% more frequently of a cardiac disease as compared to the general population. And of what do they die? They die of stroke, myocardial infarction, and the risk of sudden cardiac death due to ventricular tachycardia or fibrillation is elevated 3 times as compared to the general population. Now, what mechanisms lead actually to the fact that people with epilepsy have a higher risk of dying because of a cardiac cause? Well, obviously, the epilepsy itself could be a contributor. There are genetically caused epilepsies that might also induce cardiac arrhythmias. There could be alterations of the autonomic function, or even the localization of the seizure generator could have an influence on the risk of dying of cardiac death. But obviously also anti-seizure drugs can have effects on the cardiovascular risk factors and on cardiac properties. And seizures themselves, they can have manifold effects on the cardiovascular systems, but also remote effects caused by recurrent seizure activities. And today, we are going to focus on these different topics. And derived from this, I suggest an agenda and obviously your learning objectives, how to recognize the potential impact of anti-seizure medication on heart properties. And this sketch is just to illustrate that obviously anti-seizure drugs, they work and act on sodium, calcium, and potassium ionic channels, which are usually voltage dependent. And these channels, they're not only expressed in the brain, but also in the heart. And this is the reason why obviously anti-seizure drugs, they can also have adverse effects on cardiac function. And basically everything you can imagine has been associated with the use of anti-seizure drugs, such as sinus node dysfunction, AV block, atrial fibrillation, ventricular tachyarrhythmia, bradycardia, and impaired contractility. But this is very important to retain. You don't have to be afraid of using anti-seizure drugs or sodium channel blockers, but you have to be very cautious if you use them in very high concentrations or very high doses in combination, let's say 2 or 3 sodium channel blockers in one patient, or in combination with other anti-seizure drugs in high doses. And in these cases, you have to be aware that they can develop these cardiac arrhythmias. In general, the use of anti-seizure drugs is also independently of epilepsy an established risk factor for sudden cardiac death. And in this case control study, you easily recognize that obviously sodium channel blockers, they have a slightly higher risk of sudden cardiac death as compared to non-sodium channel blocking agents. But again, just by using anti-seizure drugs, you have an increased risk of sudden cardiac death elevated 2 to 3-fold. What could be eventually one of the underlying reasons or causes? Now, obviously, some of the anti-seizure drugs, they can increase body weight because they increase appetite. But also, we know that especially the older anti-seizure drugs, especially those which are enzyme-inducing or inhibiting, they have a very detrimental effect on circulating cardiovascular risk factors, such as the lipid profile and so forth. And we know from clinical studies that a switch from enzyme-inducing or inhibiting anti-seizure drugs to other drugs has a very good effect on the lipid profile and circulating cardiovascular risk factors. And how could these cardiovascular risk factors, how could it be linked to the risk of stroke or myocardial infarction? You know that the intima media thickness is correlated with the risk of stroke or cardiac infarction. And we know from a nice clinical study that the chronic intake of carbamazepine, phenytoin, or valproic acid correlates with the intima media thickness, linking both the circulating cardiovascular risk factors and the elevated risk of stroke and myocardial infarction. The second big topic today is to make you understand the clinical significance of the most important acute seizure-related cardiac complications. Again, on this introductory sketch, I just want to stress that the brain and the heart interact and communicate via different pathways, and that the brain communicates with the heart via a direct nerval and an indirect neurohumoral pathway. And interestingly, the brain areas which are linked to cardiac modulation are hotspots in the field of epileptology. For instance, the amygdala and the hippocampus, the insula, and the cingulate gyrus, they are often very frequently seizure onset zones. And at the same time, we know that they directly stimulate and modulate cardiac activity. And therefore, it is not surprising that almost all types of cardiac dysfunction and arrhythmias were described in association with epileptic seizures, such as bradycardia, bradyarrhythmia, up to asystole, but also sinus tachycardia, ventricular tachyarrhythmia. There are AV blocks described in association with the seizures, or new onset of atrial fibrillation. And maybe the most impressive cardiac dysfunction is the so-called Takotsubo cardiomyopathy, which is caused by an excessive release of catecholamines, especially during tonic-clonic seizures. All of these different cardiac effects and complications can in principle lead to a decrease of cardiac output, and thereby leading to syncope, sudden cardiac death, or SUDEP. SUDEP is the sudden unexpected death in epilepsy, which is not due to any known cause. As usually in medicine, the benign conditions are very frequent, such as sinus tachycardia, occurs in many focal seizures, whereas the more difficult and worse complications are rare, such as asystole, Takotsubo, cardiomyopathy, atrial fibrillation, and so forth. They were reported much rarer than other cardiac effects of epileptic seizures. So what would be the potential significance of sinus tachycardia? This is defined as a heart rate increase by at least 50% or maybe above 100 beats per minute. And this occurs in most focal seizures. in almost 100% of tonic-clonic seizures. And this heart rate increase starts early within the seizure, and it can sustain up to 30 to 60 minutes after a tonic-clonic seizure. It's usually benign, and it can be used for non-EEG based automated seizure detection devices, as you've heard or you will hear in 2 talks from Shandor Benitsky. So what would be the clinical significance of ictal asystole? This is commonly defined as RR intervals larger than 3 seconds. It commonly lasts about 20 seconds, and it's found in up to 0.3% of people with refractory epilepsy undergoing video EEG monitoring. It almost exclusively occurs in focal seizures of temporal lobe epilepsy, and it's frequently, and this is the important point, it's frequently associated with syncope and falls. And the recurrence risk of ictal asystole amounts to 40%, meaning that if you have a patient in your video EEG monitoring unit with ictal asystole, it's very likely that this person will suffer again from ictal asystole. And therefore, you should consider the cardiac pacemaker implantation if you cannot reach seizure freedom. And here's a typical example of an ictal asystole. The seizure is already ongoing. It's bilateral here. Have a look on the lower red signal. This is the ECG trace. Seizure is still ongoing with manual automatisms. But you can already recognize that the heartbeats slow down, and now you have a systole. So this is the reason why I've shown you this particular ictal asystole, because we don't believe that people with ictal asystole, they die, but they have an elevated risk of falls and injuries. And this is the reason why we believe that they need a cardiac pacemaker if seizure freedom cannot be achieved. So this patient has not had any injury in our video EEG unit, fortunately. So now I want to come to my last part of this talk, and I want you to understand the detrimental remote effects of epileptic seizures on cardiac properties. Now imagine that you have a tonic-clonic seizure, and we know that during tonic-clonic seizures, people suffer from hypoxemia, and they have an excessive catecholamine release, which leads to myocardial microinjuries. Now this is for one seizure, but imagine that people, obviously they have many seizures during their lifetime, and this leads to an incremental damage of heart and coronary vasculature, which then leads to electrical and mechanical dysfunction. And this is coined as the concept of epileptic heart. And what type of cardiac features could eventually indicate the development of the epileptic heart. And we believe that, for instance, the reduced heart rate variability, but also the altered cardiac repolarization properties and the impaired diastolic relaxation, which were all shown in people with chronic epilepsies, are a result of the incremental damage induced by repeated surges in catecholamines and hypoxemia. So why is it so important to have a look on the cardiac repolarization features? Because obviously it facilitates ventricular tachycardia if it's abnormal. And you probably know all from your cardiology lessons during your studies or your clinical training, that the repolarization phase indicates the T wave, and this, in cellular terms, is mirrored by the repolarization of the action potential. Now, the dangerous aspect about this phase is that the longer this repolarization phase is, the higher the risk is that an additional heartbeat falls into this repolarization phase, where it could trigger, for instance, recurrent cardiac activity. This could lead then to ventricular tachycardia and fibrillation. And in clinical use, there are many features that can describe the properties of cardiac repolarization. For instance, the most, let's say, known one by each and every clinician is the lengthened QT or the abnormal QT prolongation, which occurs in 6% of the seizures and 12% of the patients. So it's not unusual in people with epilepsy. But there's also the phenomenon that if the cardiac repolarization shortens too much, this can also increase the risk of ventricular tachycardia. And this is very frequent, especially in tonic-clonic seizures. But there are other features such as QT dispersion, ventricular late potentials, which are also more frequent in people with epilepsy as compared to the general population. And one feature might be of high importance in the connection between heart and sudden cardiac death in people with epilepsy. And this is the so-called T-wave alternance. And what is this? T-wave alternance is the beat-to-beat alteration of morphology or amplitude of the ST segment or the T-wave. And it's basically a measure of time and space-related heterogeneity of cardiac repolarization, which is a bad thing. The higher T-wave alternance is, the more likely the onset of ventricular tachycardia is. And T-wave values above 47 microvolts are abnormal, and above 60 microvolts, these are highly pathologic, and they indicate an elevated risk of sudden cardiac death and cardiovascular mortality. Now, in people with newly diagnosed epilepsy, the maximal T-wave alternance is still below this very pathologic threshold. But in people with chronic epilepsy, this is usually above the abnormal threshold, again indicating that there is a concept or there is a condition such as the epileptic heart, which depends on the brain, on the heart aging and the number of repeated seizures with surges of catecholamines and hypoxemia. And this is an example of what is the particular risk if this T-wave alternance jumps from a normal level to an elevated level. So you see here a patient with an ECG patch, and obviously here during the first 10 minutes, T-wave alternance is normal, but then it jumps to an elevated level and the patient suffers at that time from ventricular tachycardia. Now, what is very interesting is also that epileptic seizures, especially focal to bilateral tonic-clonic seizures, they increase T-wave alternance, especially at the end of in the post-ictal phase of a focal to bilateral tonic-clonic seizure. As you can nicely see in this graph, which shows the T-wave alternance absolute amplitudes against the time of a seizure. And the the black bars indicate the focal to bilateral tonic-clonic seizures, and you see a maximum of the T-wave alternance roughly 4 minutes after seizure cessation. And To what could these elevated T-wave alternance lead? For instance, to the onset of ventricular tachycardia after a tonic-clonic seizure, as indicated in this case report. So this is a 51-year-old female patient with temporal lobe epilepsy, no known cardiac disease. She suffers from a tonic-clonic seizure, and this is at the end of the tonic-clonic seizure with probably an elevated T-wave alternance, and she develops ventricular tachycardia, which develops into ventricular fibrillation. So why is this feature so important for people with epilepsy? Because we've recognized and learned that T-wave alternance can be counteracted and compensated by vagus nerve stimulation. So vagus nerve stimulation is the trial of controlling epileptic seizures by repetitive electrical stimulations of the vagus nerve, usually of the left vagus nerve, every 5 minutes for 30 seconds. And we know that many patients, they benefit from this type of treatment with an improved seizure control. And this was the first study that described that the vagus nerve stimulation can actually improve T-wave alternance, as indicated here. So in blue graphs indicates the T-wave alternance 2 months after VNS implantation. You see in all these 6 patients a nice decrease of the T-wave alternance level in all different kinds of ECG derivations. And this interesting finding was actually confirmed and repeated in another study with about 30 patients, where the authors have investigated T-wave alternance during baseline and some weeks after VNS implantation. And again, VNS implantation has led to a significant decrease of T-wave alternance below the abnormal level. And this is interesting because we know from another condition that VNS can also lead to a substantial decrease of the risk of cardiac arrhythmia. And this study was performed not in epilepsy patients, but in people with heart failure. They've been implanted a VNS to increase the cardiac performance. But importantly, these patients on VNS, they had a reduction of episodes with ventricular tachycardia by more than 70%, which already suggests that obviously a VNS could decrease the risk of potentially fatal ventricular tachycardia. The VNS obviously has also some effects in people with epilepsy. We know from a large cohort study in the US that the SUDEP rate, so the risk of dying suddenly, can actually be decreased by the use of VNS. So in these people, in more than 40,000 patients with VNS, have been studied in this cohort investigation, and upon year 3 to 10, the SUDEP rate decreased from 2.6 to 1.8. So it was roughly 30% decrease of SUDEP rate in people who have been treated with VNS. Now, the SUDEP is defined as the sudden unexpected death of a person with epilepsy, which is witnessed or unwitnessed, with or without evidence of a seizure, and which actually occurs under benign circumstances and where the postmortem is without any apparent cause of death. And the SUDEP has gained a lot of attention and awareness because obviously it is a very impressive complication of epilepsy and of seizures, because it's the unexpected death of a person with epilepsy. And how do we think that SUDEP occurs? So at the moment, we believe that a tonic-clonic seizure leads to, at the end of the seizure, to a generalized suppression of brain activity, which then again leads to a suppression of brainstem function with coma, impaired protective reflexes, impaired arousal function, and a suppressed or impaired respiratory drive. And this then obviously leads to central apnea, severe hypoxemia, and then to terminal asystole. So this is what we believe that most SUDEP cases are caused by at the moment. And the maybe important aspect is so that most SUDEP cases, we believe that roughly 90% are caused by acute seizures, and that they occur more likely in younger people between 20 and 40 years, whereas the sudden cardiac death occurs mostly in people above the age of 40, and it's only in 1/3 of the cases directly seizure-related. So 2/3 of the cases are not directly seizure-related, but could be explained by the condition that was coined the epileptic heart. So if you want to talk about numbers, although SUDEP is very impressive and it's the risk of dying suddenly in people with epilepsy is elevated more than 20-fold as compared to the general population, the absolute numbers of people dying in SUDEP is about 4 to 5 times smaller than those dying of sudden cardiac death. So sudden cardiac death and the epileptic heart is an important feature that we have to be aware of and try to reduce somehow the sudden cardiac death rate in people with epilepsy. Obviously, some of the SUDEP cases and the sudden cardiac death cases overlap. So sometimes it's not possible to make the distinction between SUDEP and sudden cardiac death. But the overlap is probably not very high. So I want to sum up, and I hope I've explained to you the concept of the epileptic heart, but also I've talked about other cardiac complications in people with epilepsy. I told you that people with epilepsy have an increased risk of cardiac disease and sudden cardiac death, and that anti-seizure drugs may be switched, especially the older ones, and that its mechanisms of action matter. So please be aware, don't use high doses of combinations of sodium channel blockers. I've also shown you that the transient seizure-related cardiac disturbances are common and manifold, and that sinus tachycardia is the most frequent one, and it can be used probably for seizure detection devices, and that ictal asystole is rare but has a high recurrence risk. So if you have identified a person with ictal asystole, you should consider implantation of cardiac pacemaker if seizure freedom cannot be achieved. And finally, I explained the concept of the epileptic heart and the acquired cardiac damage by repeated surges of excessive catecholamines and hypoxemia, which then leads to altered features of cardiac repolarization, which again increases the risk of ventricular tachycardia, which is obviously one of the major reasons for sudden cardiac death. And especially one specific feature, and this is the increased T wave alternance, can be improved by vagus nerve stimulation. Thank you very much for your attention, and I'm looking forward to your questions.